She's 28 years old and she has been diagnosed by some orthopedician as a abscess right thumb, and the ultrasound report indicate abscess inside the proximal part of the right thumb. But she says that this swelling was for last few years, say 1.5 to 2 years, and there was no significant pain. That exclude clinically that it cannot be a abscess, right? So now the surgeon tried to make multiple punctures and tried to suck out the pus, and in fact the diagnosis was wrong, and ultrasound finding was also wrong. So I have asked for the MRI of the right thumb. This suggests the diagnosis in favor of giant cell tumor of the thumb. This is also known as Xanthoma or xanthomatous tumor. This is the second most common tumor of the hand, and most of the time it originates from the tendon sheath. The recurrence in this case is quite high, and the literature says it is from 5 to 50% recurrence. Right? Now, this must always be done. The surgical procedure must always be done under tourniquet. It can be done under GA. It can be done under brachial plexus block. And in this patient, I have already given the brachial plexus block, and the block is successful. Right? Now, you can notice the mass in the proximal phalanx of the thumb and multiple holes of prick that was done by the surgeon previously. Now the important thing is, after applying a tourniquet, I used to keep the tourniquet 60 mm of mercury above the systolic BP of the patient. An important thing for this is exposure must be appropriate. If you are making a incomplete or inadequate exposure, you cannot, or sometimes you cannot remove all the lesions, because this is aggressive, localized tumor, and recurrence is very high. Right? Now, basic trick behind this is, after exposure, you just pinpoint or localize the proximal neurovascular bundle and distal neurovascular bundle. Localize, dissect, and make sure that these bundles are exposed proximally and distally. Then gently you just enucleate out the ultrasound. The MRI shows in this patient that this originates from the tendon sheath. It is just behind or the deeper to the flexor tendon. It is more on the ulnar side and less on the radial side. So the incision I am planning, because the limit is here and the other limit is here. So I will make the incision like this. I will make incision. This can be further extended. So he will make incision here, and here, like this, and I will leave behind. If there is inadequate exposure, we will extend little bit on this side. Right? This is the incision, like this, because this is the radial limit and this is the ulnar limit, because this is extending this side. So initially I will open from this incision. This can be extended dotted line, dorsally or ventrally. So initially this incision, and that is the important things. Okay. Then at this point, so according to need, I will extend the volar or the dorsal aspects. डेस्टिनेशन तरफ बेटा, रोशनी तरफ रखो उसको, ये बिल्कुल, हाँ ये नर्व है, इसको घुमा बेटा, इसको पकड़ लेगा, इसको हम यूं भी कर सकते हैं एक्सचेंज, ठीक है। तो भी हो जाएगा नहीं, nerve here, nerve rotated, no. Now you can notice, and the trick behind removal is you explore the neurovascular bundle proximal and distal, and then now here the tumor is coming out from the flexor sheath that I will show you here. This is the tendon sheath here. Now this is the tendon sheath. Now this is the tendon sheath. Now it is also deeper penetration. इसको भी सारा के लिए इस्तेमाल हो रही है।
इसमें क्या होगा?
Now we will separate this tissue. Here you can notice that the tissue is going deeper to the flexor tendons. Alright. So now excise the sheath of this tendon also. Now I am just retracting this tendon here. Now to set this sheath, this pulley, let it in proximal part, and then see it is there. It is quite deep. Now just retract. Now so working in the deeper plane. ऐसे रखो बेटा. Carefully separate out all the tissue. तो कुछ भी खींचना नहीं. It's deep. It is now this the tendon here is quite deep in the tendon sheath. The nerves, neurovascular bundles are there. Now open this sheath, open it, just separate it out. Now this is the bone here. The periosteum and keeping it with the tumor mass. Right? Sometimes this also originates or is adherent to the ligament, and you have to remove that ligament also. This is the destructive procedure. Now this bone है, इसके लिए कैप्सूल से जोड़ रहे हैं. Nothing, because I have separated out the tissue here. Just maybe cutting it. Yes. Now, this is the bone here. This is the tendon. This is the neurovascular bundle. The tendon and this. So this is adherent to the capsule also.
Of the joint.
Of the joint. So remove everything in toto. These are the one neurovascular bundles, so don't get it. See, this is adherent to capsule also. Now this I have removed. This tumor I have removed. Now this part was deep to tendon. See, this part was quite deep to flexor tendon. You can see this piece, and there is some resorption of the bone also. And this capsule is adherent to. This is the capsule of this joint. It's adherent to this capsule also. So we have removed in toto. Now I will see, trim it out. Trim it out. So I think I have removed. There is nothing left behind. It's all clean. Now this is the bone here, and there is a resorption of the bone. And this deep part is here in this cavity. This is the tendon. This is the neurovascular bundle on this side, and this is the extensor tendons, right? The extensor tendons are there. Now this operation is complete. Now I will suture. I will release the tunicate, and then I will just suture it with 5-0 proline. I have removed it after excision, complete excision of the xanthomatous or xanthoma or giant cell tumor from the right thumb. I removed the tunicate within 1 hour, and after that I am just repairing. I am closing the wound with the help of 5-0 non-absorbable polyethylene thumb, and this was removed in toto. Here you can notice the tissue was adherent. This part of this hard tissue is the joint capsule, because this arises from the interphalangeal joint of the joint. This is very tough, and this is part of the capsule I have removed, and periosteum of the proximal phalanx was also peeled out. Now I am turning this specimen. Here you can notice this bar. See, this gutter is for the tendon here. This gutter is for the flexor tendon. So this part deep, in fact this was lying like this. So this part the deeper structure. So for the histopathology I am sending this.